Hello and welcome everybody. Thank you for joining us for today's session of Surgery Online. My name is Magdalena Schweissgut. I am a product manager at MED-EL headquarters in Innsbruck. And I am really excited that today we can watch together two ossicular reconstructions with a new length adjustable system. One is done by Professor Dr. Ihler from the LMU clinic in Munich, Germany, and the second one is done by Prima Dr. Paul Martin Zwittag. He is the head of the ENT department at the Kepler University clinic in Linz, Austria. But before we go ahead and watch the surgeries, I would really like to go through some recommendations from our side, which that will make the next hour as pleasant and informative as possible for all of us. Okay, so please name yourself with your full name. You can change your name by clicking on your name in the participant panel, and then on more, and then you can rename yourself. To avoid background noise, we would kindly ask you to mute your microphone if you don't speak, and also to mute your phone. Of course, in the end, when we come to the questions and answers part, you can unmute yourself and you can talk directly to the presenters. Also, for a stable internet connection, we would recommend to close all other programs that you have open on your computer or your device, so that everything runs as smoothly as possible. And most importantly, all of your comments and questions and feedbacks are welcome, so feel free to type them in the chat anytime. We will go through the questions and comments after the second surgery, and so that we can answer all of them. I'm also really happy to have Uwe Steinhardt in the audience as an expert when it comes to developing and producing passive miliary implants. So if you have a question burning that concerns this topic, please feel free to use this occasion to ask Uwe Steinhardt this question. Okay, so last thing that I want to mention before we go ahead and watch the surgeries. First of all, if you need captions, please activate them in the lower menu in the Zoom screen. You can find there the closed caption button, and by clicking on it, you can enable the captions. This will help, of course, with understanding. And another thing is that I would just briefly want to show you the implants that will be implanted today. So this will be the new length adjustable system from MED-EL. As many of you know, we have added the passive miliary implants to our portfolio recently. The reason why we did this is for us really obvious. We want to help as many people as possible to overcome hearing loss as a barrier to communication and quality of life. And of course, by adding the passive miliary implants to our portfolio, we are able to help even more people. And this is really our ultimate goal, and this is what we are passionate about. And this is also why we are really happy now to offer the complete portfolio of hearing implants. Okay, so today we will see two ossicular reconstructions. Professor Ihler will show an MXEC Pro partial prosthesis, and Professor Zwittag will show an MXEC Pro total prosthesis. So both implants can be adjusted in their length, and this can be done inside the box in which the implants are shipped. And this is also possible without any predefined steps. So there are no increments that you have to observe. And so within that range, any length is possible, basically. Also, you will see that Professor Ihler and Prima Zwittag don't use any special tools, so no special tools are needed. They just use titanium tweezers and a scalpel to adjust the length. So it's all that is needed. Also, an interesting point for you to know is that the bell of the partial implant can be rotated before the head plate is fixed to the shaft. And with this, of course, the orientation of the bell and the head plate can be adapted to the individual's patient's anatomy. So this is also really nice. Okay, but this is now almost forgot, because I don't want to keep one special thing from you, which is another implant that will come soon. It's the M-Clip Arc. And as you see in this picture, this implant will have a ball joint between the head plate, the round head plate, and the shaft. And of course, with this, it will be able to adapt to movements of the tympanic membrane. We won't see this implant yet today, but of course, later in autumn, we will also demonstrate this prosthesis in a Surgery Online event, and you will, as usually, get information up front so that you can save the date for the event. Okay, now enough talking from my side. I would now hand over to Professor Ihler. Professor Ihler, can you hear us?
I can hear you. Thank you very much.
Perfect. Thank you for joining. We are excited to see the surgery, and I would like to ask you to show or to share your screen now.
Okay. And here it is. I hope you can see it. First of all, thank you very much for the opportunity to work with this new implant. We use it with a 83-year-old lady who presented initially with unspecific episodic vertigo, no sign of fistula, but most likely vestibular migraine, and she had a dry ear, but she also had a cholesteatoma in the pars tensa of the eardrum in her left ear, and that was the reason for the operation. And you can see the CT scans and coronal and axial reconstruction on the right side. It is not very big, but it was located medially to the ossicular chain. So the malleus head and the incus had to be extracted, and there was the stapes and the stapes head still functional. So there was need for this partial prosthesis for ear reconstruction. You see the audiogram on the left side in blue with mixed hearing loss, as one would expect from the disorder. So much for the presentation of the case, and we can go to the video now. And we start the reconstruction with the preparation of the cartilage perichondrium island graft that we harvest from the cymba of the ear cartilage. We aim to make it really thin to provide good sound conduction. And we need a wide overlap of perichondrial tissue for sealing of the middle ear when the transplant is in place. So this is the graft, and we transfer it now to the middle ear. You can see the chorda tympani that was preserved on the right side, and medially to that the facial nerve, and on the left side the head of the stapes that will be coupled to the implant soon. Now we make the positioning of the transplant. It's very important that there's overlap with the remaining eardrum tissue. The handle of the malleus and the tensor tympani was preserved and can be used for stabilization of the transplant. And this is the implant as we open it with the box. From my point of view, it's very nice that the sizers are included. So there's no need for additional storage or an additional thing that has to be opened or that probably might be not available. And in her case, it was between 1.0 and 1.5 millimeters of functional length, as you can see from the sizers. So this was the first one. I tried the smaller one consecutively. And of course, the sizers give a good estimate, but I think it makes the system very flexible, that it is possible to adjust it to the real length that is needed at the end, and there is no there are no increments and no steps between. It's really flexible. So this is the 1.0 sizer. This one was a little bit too small, so later I went for a little bit higher length. Okay, very important to seal the tympanic cavity with the graft, of course. So I hope you can see the video really good. And with the length that is estimated by the sizers, one can go to the box with the implant again and adjust it to the length as it is needed for the particular patient. And do that now. I hope so. No, not yet. I'm sorry. Here we provide for good overlap. Again with the eardrum. And it's nice and stable, the transplant. And now waiting for the implant. So here again is the implant. And we can adjust it to the length as needed. So it was a little bit less than 1.5 millimeters. And to close the head plate, we use forceps that we usually use for microsurgical application. So there's no, there was no need for additional instrumentation from our part. A little hurdle can be the removal of the retractor. But first of all, with unusual scalpel, we remove the excessive length. And this is gone now. Okay. The removal of the implant from the box can be challenging if you do it exactly like this. So this is not the optimum. I learned later. It's quite easier when you take the prosthesis and this retractor both in the middle and pull it directly then it cannot be stuck, but this is only a minor issue. So we usually take the implants with suction to the ear, and then it can be placed on the head of the stapes. As we've seen before with the scissors. Yeah, again, it's quite nice that it's possible to go for a length in between as well. So a quite flexible system from my point of view. So again, when opening the middle ear cavity, the chorda tympani should be preserved, of course, when it's possible, when it has been possible to preserve it during all steps of surgery, of course. And now we place it on the head of the stapes. And that is possible now. And as you have seen, probably the stapes is quite mobile. So there's a situation that can lead to good sound conduction in the end. Okay. So now the prosthesis is in place. Just make sure that it's well positioned, and yeah. So now it is done, and the surgery was last week, so we don't have the follow-up results yet, but I'm confident that the patient will get a good result from this procedure. So the last step we will see shortly is when I put the skin of the ear canal back in place. That is something we usually do in cases like this, that it is temporarily removed, and yeah, it is healthy skin that can be used for a healthy self-cleaning ear canal in the future. So here the remaining annulus that is placed on top. This is the ear canal skin that is put back in place. Again, we take care for a good overlap with the perichondrium transplant. And the final steps you won't see here are silicone and Chilita to close the ear canal for the healing period. Yeah, thank you very much.
Thank you so much, Professor Ihler, for sharing this really nice surgery with us. I thought it was really interesting, and I'm looking forward to discussing it later and to answer possible questions from the audience. So this is my call to the audience. If you have questions to the procedure from Professor Ihler, please feel free to type them into the chat now. And we will then later, after the surgery presented by Prima Zwittag, go through the questions. And with this, I would like to hand over to Professor Zwittag, Prima Zwittag, I'm sorry. Can you hear us?
Yes, I can hear you. I hope you too.
Perfect, we hear you really nicely. So you can start whenever you're ready.
Okay, thanks. We can start. I think so. Yeah, good afternoon. Also, hello. My name is Zwittag from the ENT department in Linz in Austria, and I'm very happy and glad to present you the new passive middle ear implant. Yeah, and at first I will tell you something about the patient. I hope the video works. Yes, it works. We have a 40-year-old man which come to us with a conductive hearing loss since 20 years. The last surgery was in the year 2001. Unfortunately, we have no operation report, no doctor's letter, because the patient came as a refugee from Iraq. So we only knew that some operations were in the past. He had no middle infection since 20 years, no dizziness, no facial problem, no pain. And in the audiometry before the surgery, we can see a conductive hearing loss in the left side between 20 and 35 dB. Yeah, also we did a CT scan to see before the surgery what is the problem, and we can see the stapes foot plate, but missing the totally ossicular chain and the tympanic membrane, and then a very, very small middle ear cavity. So let's go. This I will explain later. So the surgery with a small skin incision after local anesthesia at 3, 6, 9, and 12 o'clock, called by Hermann. I like the transcanal approach for this type of surgery. And then we look directly to the tympanic membrane. You can see a bleeding situation. The structures are scarred. It's not easy to do the preparation. There's no really good anatomy. So I was looking very softly to find an annulus or an sulcus. In this case, we can see that the rest of the tympanic membrane was softly removed, and some cartilage is coming in the middle. Here, a short view to the rest of the tympanic membrane. It was lying directly on the promontorium of the cochlea. The preparation will start again, step by step. To get a better view, I use the diamond burr, 2.5 millimeter diamond burr with automatic cleansing system. It's very nice with this function. It also stops a little bit the bleeding and to get a better view. So the drilling helps to work a little bit with more space. Now I can start again the preparation step by step to find as next the facial nerve. A quarter tympani was missing. Also no ossicular chain. We can see some cartilage parts, I think, from the last surgery for 20 years. They will clean from the rest of the tympanic membrane. I was very carefully because I'm not sure where is the facial nerve coming, also the oval foot plate. So now we can see the cartilage is in a bad condition. It fractures. It's all the one, and I will remove it totally. And now we can see a little bit the facial nerve in the center. It will look very dominant, and it will come the oval foot plate in a few moments. So the rest of the cartilage will be removed, and I'm cleaning the cartilage from the facial nerve. I have in the left hand the suction, in the right hand the needle, and with the suction I always be in the left side of the facial nerve. Yeah, also the rest of this tympanic membrane part of the promontorium will be removed. Here we can see at 9 o'clock there is the round window coming, and you see there's no air between the tympanic membrane and the promontorium, a really small cavity. Yeah, and here we see the facial nerve with a nice vascular perineurium, and I clean the foot plate very, very carefully, also with a small hook, step by step, and to feel if I can feel some stapes superstructure. And now it was a little bit surprising. We can see it in a few seconds. So I was moving the scarred structures of the oval foot plate. It wasn't easy to go a little bit easier. I removed the rest of the eminentia pyramidalis. Yeah, we can see a big facial nerve in the center of the video. On the left side, the oval foot plate with maximum zoom. Now, very carefully with the suction on the oval foot plate. And this was, yeah, untypically, I removed the structures, and now we can see it immediately. Here we can see it, the inner ear was open. I think in the last surgery, the foot plate was removed, or it was destroyed. So I put it in some Gelita with cortisone to save the inner ear. We also gave cortisone by the anesthesia. Okay, now I make the cartilage preparation. It's Andragus cartilage graft with the butterfly technique I learned from Mario Sana, also some other surgeons like Moser Gerhard from Salzburg showed me this technique. It's very nice. You remove one side from the perichondrium, from the cartilage, and make a butterfly. In Austria, we call it also Wiener Schnitzel. It's the same way as we do and make the Wiener Schnitzel, by the way. So you can see this double layered graft, and I will remove carefully the cartilage on either side with an Fria elevatorium. It's good to prepare it with the Fria, but be carefully that you don't destroy the perichondrium on the downside. So the last side, I also will remove so that we have an insel cartilage perichondrium graft, double layered, and to sign it out, I take also the knife in a few seconds to get a thin, good graft. So here's the butterfly. Yeah, that's it. The graft is ready. Looks good. It's a big graft, also to seal the outer ear canal and to get in good position for the head plate of the prosthesis. This small part of the cartilage is used to save the oval window. In this case, I didn't do some center perforation, only a small piece of cartilage. So, yeah, that wasn't enough good for me, so I removed another part. So I think, but it's ready. And now we can go to the prosthesis. And as we can see, with a fine forceps, I can crimp the head plate now. Sorry, there's some noise in the video. I think somebody has his microphone on. So I sealed the head plate at 3 millimeter lengths. I was using the sizes before, this isn't on the video. And then I also cut it off the excess shaft with a knife. Here I show it, if you don't use so much strength, the shaft will not go off. Here we can see. It looks like it is off, but it isn't. Don't trust it. Here we can see it. So I used the knife a second time with really strong cutting. And then you hear a small click, and then you know that the shaft is over. So the shaft will be removed, and the prosthesis can be used. I also wasn't as good informed to access the fixation part, but it works really nice, and the prosthesis has a nice stability. It can be formed. I will show it in the next step a little bit with more detail. We have a 3 millimeter total prosthesis with a good crimping head plate, and with a 0.5 millimeter or 0.12 millimeter excess shaft on the head plate. I like it to save the cartilage of the graft a little bit. So I zoomed in so you can see it very nicely. Looks really, really good. So the prosthesis come to the patient in the outer ear canal now. Yeah, here it is. I have to apologize. This part of the surgery, our video system was a little bit tricky, so it's not the best picture now. I saved with this small piece of cartilage the oval window. You can see on the right side this white shining facial nerve, and here the oval foot plate. Very, very carefully to save it, that no more perilymph will go out of the inner ear, as we know this from the step-bedo or staphytectomy technique. So the 3 millimeter total prosthesis will be positioned on the cartilage. I have always on the left hand a small suction, 0.7 millimeter suction on the right side. The needle, I will make it in a good position. The prosthesis is over the facial nerve, having good standing in the knee of the eminentia pyramidalis. To save it a little bit more, I will give some small Chelita with cortisone at 9 and 3 o'clock. As you can see now, on 9 o'clock, yeah. And also at 3 o'clock, a small piece of Chelita to get a good stabilization for the next week. I also did this operation, this surgery last week in our department. So, and in this situation, the next step, the perichondrium cartilage graft is coming. In the most cases, I also will put the graft at first in the middle ear, and then I will put the prosthesis on the right position. In this special case, I decided to do it otherwise because the inner ear was opened. It was necessary for me to save as soon as possible the inner ear. Here I removed another part of sclerotic pieces of the tympanic membrane to get a good vascularity and perfusion situation of the tympanic membrane. So this is the rest of the original tympanic membrane, and as next step the graft is coming. This big butterfly graft, which will be positioned in the center of the head plate of the prosthesis. So I hope it comes. Yeah, this was preparation. Yeah, here it comes. You can see this island cartilage perichondrium, double layered or butterfly graft. Now the cartilage will be positioned over the head plate. This works really nice. It's easy to get in good position. I always feel with the needle the head plate, so you can feel a little bit of the head plate if you put on it. I also look before the end of the surgery under the graft to see again the prosthesis, to see if the prosthesis works and has a good position. Yeah, here's the head plate under the cartilage and a small look to the prosthesis. You can see, yeah, it's okay. So, and I save it with a silicone layer, in most cases 2 pieces, and I package the outer ear canal with cortisone Chelita. Okay, I think that's it. The second audiometry was to check after the surgery, to check the inner ear function. It was good. So I hope you enjoyed it. Thank you for watching.
Thank you, Prima Zwittag, for sharing this really interesting and difficult surgery with us. I definitely have now a new association with Wiener Schnitzel, but I think there was really a funny side piece to this really interesting surgery. I am sure that there will be lots of questions and comments on both surgeries, and I see that we have already one in the chat by Lukas Osel, and he asks, would you recommend any treatment of the hearing loss during the healing phase after the implantation? Do you usually do that? Professor Ihler, maybe you want to go first?
Yeah, we check the inner ear at the day after surgery, and in case there's the slightest drop, we administer cortisone intravenously and check it the next day again. I think this is quite usual.
So I think what Lukas Osel wants to point out is that there is a time period where the patient doesn't hear due to the tamponade and due to that the ear canal is blocked with the tamponade. Do you usually offer the patient an additional hearing aid or a device that can so that they can hear in this phase?
So that's no common practice in our hospital because it's only 2 weeks. What we don't do is that we do ear procedures on both sides, of course, because that is very strong limitation on quality of life. We don't hear at all, but usually with one ear it's quite well tolerated, and it's over after about 2 or 2.5 weeks.
Perfect. Prima Zwittag, what is your opinion on that?
I have the same opinion as Professor Ihler. We also don't use some hearing aid for this time because it isn't a long time period, and we also will do only one side of the ear to save the other side for hearing for the hearing situation. So it's the same situation. I think a special situation is if a patient has a total hearing loss on the other side, then we can talk about an bone hearing aid, but this is really in a really rare situation, I think.
Okay. What do you estimate? How long does it take until the middle ear is fully healed after the surgery? So not just the tamponade, but really all the fluids is gone from the middle ear.
Okay, for me the question, it's the most cases between 6 and 12 weeks. We also removed the silicone layer and the tamponade after 3 weeks of the surgery. Then you can see it's only a little bit wet. It has to dry, and it will work. It will work even better if the time is longer gone away from the surgery, but it works.
Okay, thank you. So another question, would it be okay if the chorda tympani is in touch with the PMEI after the implantation? Professor Ihler, what is your answer to the question?
Yeah, we try to avoid it, but yeah, the chorda tympani should be on its own if it's possible, of course. And additionally, scar tissue growth near or around the tympanic membrane graft affect the chorda tympani? Yeah, of course, but usually that is something we can see from outside, and theoretically that could, of course, make taste disturbances.
Prima Zwittag, you also try to avoid it, or what is your?
Yeah, I think sometimes it's only go with contact of the chorda tympani and the prosthesis, because we have not much place in the middle ear, but I never have seen problems with it. We can see sometimes that the patient shows out a few days after the surgery that they have some problem with tasting on the tongue, but this goes away. I've never seen any problems with it.
Okay, thank you. So a question that is really controversial, I would say, in the field is whether to keep the malleus or not. Do you have a preference on that topic? Maybe Professor Ihler, you want to start?
Yeah, the school I learn from usually aims at preserving the malleus handle because it provides good stabilization. But of course, one must never compromise with removal of the cholesteatoma. This is the absolute first priority, and the second priority is, of course, preservation of the structures.
Prima Zwittag, for you the same?
Yeah, I can agree totally. It's the same thing. If you have an malleus, it's good for the stability. As you have seen in my situation, there was no ossicular chain. It also works, but it's always necessary to use some cartilage to save the prosthesis in a better position. But it's better to have a malleus. But if the diagnosis is in cholesteatoma, then all must be removed if it had contact with it.
So do you see the malleus more for the stability of the tympanic membrane and for the reconstruction, or do you see also better outcomes with the malleus? Professor Prima Zwittag.
Also, I don't see better outcome. I'm not sure that it makes a difference. It's better for the surgeon if you have it. It's easier to make a good placement of the prosthesis. But in the hearing outcome, I think it doesn't make some difference.
Did you see some difference, Professor Ihler?
I think from a global point of view, a more stable reconstructed eardrum will most times have a better outcome. But I don't think that the malleus or malleus handle is of great functional relevance beyond that. Yeah.
Okay, thank you. So sorry?
I have a question, Lee.
Yeah.
A question to the surgeons. You both have now used this system for the very first time worldwide last week. And of course, I just want to ask you, there is a little learning curve with using such a new system. But what is your impression? How long is this learning curve, and how many did you train? I know that number, but can you tell this the audience? First, Professor Ihler. Second, Professor Prima Zwittag.
So I had not a big experience with a variable prosthesis. I think you have to get used to the situation that you adjust the prosthesis, but then it's, I think, very much straightforward. Yeah. Okay. I think it gives you more flexibility. I like the idea that there's not so much storage room used up with several sizes and sizers, of course. And yeah, I thought it works after a couple of tries. Yeah.
Okay, thank you. Zwittag?
Yeah, I use wearable systems since 5 years, and I have to tell I like it. It's easy to use. It's no problem. You need a fine forceps to get in good crimping situation. I think this is very, very important. In this part, it is necessary to be carefully to save the head plate, and that you should save it and don't destroy it. But I think it's no problem. You do this 2-3 times, and then you can it. Then you learned it, and then you can work with it. It's also nice to have the sizers in the package. I think this is new, and it's nice. It's really nice. And I think that this head plate with the length, I also can adjust a little bit. Has also a nice function, which is new for me. I like it. It's good.
So you like the all-in-one, everything in one box solution? I assume, and okay. And the stepless, do you think there is an advantage having a stepless length adjustable system, or is this not that important for you? Prima, Zwittag, or
yeah, for me it's important because I don't need a big storage for all procedures. So I have the important thing with a few parts in my surgery theater, and this is good. So I have all in one.
okay.
I think the situation that it is adjustable gives you a little advantage about fixed lengths, because sometimes it's actually in between two available lengths, and that gives you a little bit more flexibility, I think.
Okay.
Thank you.
Thank you.
I actually have a question on measuring the correct size. We saw or heard from Prima Zwittag that you both really measure the distance to get the correct implant length. But we also know that this is not true for everybody, so some surgeons do not measure. What do you think about that? Maybe Professor Ihler.
Well, I'm a measuring guy, I think, so it gives me the confidence that that's the right size. It doesn't depend whether you have opened something that might not fit, or whether you adjusted the length and that might not fit. So I like it to measure it first and then adjust it to the length. I think it is worth the time to do it, but of course I can think of probably for other people it might be yeah, from when you guess it from the experience, that might also be possible, of course.
Prima Zwittag, what do you think?
Yeah, I also think the measuring function is nice. Sometimes by the partial prosthesis, by the PORP, I don't use it because they have a standard length, but it's also nice to use it to see, okay, if the perichondrium graft works with the right height. This gives a good feeling, and you also can see if the stapes is saved. There is no too much length or too small length. It's good to change a little bit, and then you can decide which length is the best.
Because in your case, we also saw, or you mentioned that the cavity was really small, and that you had to use a smaller than standard length. So it was really nice to see that measuring is really important. And you did measure, but we didn't see it in the video.
Yeah,
yes,
I did measure, and I think in this case I showed it's not good to use a 5 mm long total prosthesis, because you have too much pressure to the oval foot plate, and then the prosthesis is in the inner ear. So I used a smaller one, which can work and also save the inner ear.
Perfect.
I have another question.
Bitte, Uwe.
You both used an island technique for covering the head plate of the prosthesis. I know this technique, but I did not know that it's so common. Yeah, is this a technique you always use in Munich or in Linz, or is this something you use in special situations? And what else are you using for covering the head plate of the prosthesis? Sorry, Professor Ihler. Sorry.
In cases where the ossicular chain is reconstructed, I use it always. In other cases, I think it depends on how much from the surface of the eardrum has to be reconstructed. The bigger, the more the need for cartilage. And of course, there are some cases of small and dry perforations of the eardrum that can be reconstructed with fascia, but I think most of the cases we use cartilage, perichondrium.
Okay. Prima Zwittag?
Yeah, I can agree with that. It's the same in Linz. We use cartilage for prosthesis to save the head plate, that the head plate isn't coming out months after the surgery. And for a laryngoplasty, especially, I also need fascia from the muscle, from the temporal muscle.
Okay, thank you.
So I would also be really interested, Prima Zwittag, what was going on in your head when you saw that cavity?
Must it be to make a video for this presentation? It's not a typical situation, and it's not the nice case to show a perfect quality of surgery. But it can show very good how surgery is and how a job is. You have to do a good job and to make a good improvisation, and in my case to save the inner ear, because that isn't funny that when you lose the inner ear.
Yeah.
And it shows that it can work under real life conditions as well. So it's not no staged procedure.
Yeah.
That's it.
Okay, so I see there are no more questions in the chat, and we are almost at 4 o'clock. Please, if anybody from the audience still has a question, feel free to unmute yourself and take the chance of the last 3 minutes to ask Professor Ihler and Prima Zwittag your questions. Yeah, use the chance now. Okay, no, I think everything was really clear. If questions come up, however, of course, I think you can contact Professor Ihler and Prima Zwittag anytime, or also Uwe Steinhardt or myself from MED-EL. And yeah, I would like to thank you, Professor Ihler, Prima Zwittag, very, very much for sharing your experience with us, for taking the time to be with us today. I hope all of the audience just found it as interesting as I did, and I also learned a lot in this session. Of course, we will have a next Surgery Online event already in 2 weeks, and I invite everybody to join also this session. It will be on techniques to improve hearing preservation with long lateral wall electrodes. So this will be on August 4th, as you see it now on the slide. I'm sure this will also be very interesting, and I hope to see all of you there again and very soon. Thanks again, Professor Ihler, Prima Zwittag. Hope to see you soon again. Have a good rest of the day. Thank you, and goodbye from Innsbruck.
Thank you.
Ciao, goodbye.
Thank
Good
you.
afternoon.
Goodbye.